Мы можем начинать?
В эфире начинайте.
Глубоко уважаемые коллеги, доброе
Distinguished colleagues, a very good afternoon. We're happy to welcome all of you here at our international webinar about the excellence of clinical practice in cardiac amyloidosis. And today we will enjoy the experience of excellent centers from Europe and from Russia. Today, we are welcoming our distinguished guest, Professor Fernando Dominges, who represents Heart Failure and Inherited Cardiac Disease Unit, Department of Cardiology, Hospital Universitario de Pуэрta-de-Йерро-Маджадахонda, Madrid, Spain, and also Igor Žirov, who represents National Center of Cardiology, named after Chazov. And myself, Professor Sергei Terещенко, who is a doctor of medical science, professor, and the lead of the unit for myocardial disease and heart failure of Scientific Medical Center of Cardiology, named after Chazov, with the Ministry of Health of Russia. So, dear friends, dear colleagues, if you allow, I'm happy to start our webinar and very briefly to speak about the problem, about the burden of amyloidosis today. On the one hand, we know that this disease is not so rare as we used to believe. The story of amyloidosis started mainly from chronic inflammatory diseases that led to the development of amyloidosis. Later on, with the improvement of modern instrumental technological advancements with genetics and other test development, we started understanding better and deeper this pathology. And today we can say that amyloidosis is a very diverse pathology that affects not only the heart, but also involves CNS and multiple organs and tissues. And very briefly, dear colleagues, I'm happy to say that if we analyze the modern diagnostic options for amyloidosis, so currently we have multiple opportunities to make the diagnosis at very early steps of the disease. But now we appreciate paradoxical situation because our patients with amyloidosis normally had a very long journey from the first clinical symptoms, from the appearance, from the onset of the symptoms up to the diagnosis. Well, patients may come to very different doctors, to very different specialists, to ophthalmologists, to gastroenterologists, they come to GPs, to cardiologists, with their, let's say, non-specific complaints. And very many different diagnoses could be made until clear progression of the disease, specifically the development of transthyretin cardiomyopathy, the development of heart failure. And here we start looking for the reasons, what's the reason of the disease, but in fact years of life are lost and we have fewer and fewer chances to somehow terminate the progression of the disease. And finally, we may conclude that this disease, unfortunately, leads to very unfavorable outcomes. I have to say that until recently, amyloidosis used to be the diagnosis like a capital punishment, So yes, we could make this diagnosis, but we had absolutely nothing to do. We have nothing to offer to our patients, any treatment that could prevent any further progression. I clearly remember when I used to be very young and very handsome. So in those years, at the beginning of 1990s and end of 1990s or beginning 2000, I remember clearly how these patients could have been treated. So in fact, frequently they were recommended to eat raw liver to minimize amyloidosis deposits. Now we have drugs that could prevent the progression and minimize the symptoms that we are facing. And now I'm happy to move to my main presentations. So this is change of perception of transthyretin amyloidosis in Russia. We will speak about both situations in Russia and in Europe. So let's have a look. What is transthyretin cardiomyopathy? In fact, this is one of the multiple reasons of heart failure. And today, due to the non-invasive diagnostic tests, due to the effective methods of treatment, we can appreciate that transthyretin cardiomyopathy is not perceived anymore as very rare and incurable disease. Let's appreciate since what time we started paying attention to all of our patients. We all know that any new drug treatment is normally a driving force, a trigger for the further analysis and understanding of multiple diseases. And the same happens with transthyretin cardiomyopathy. And in fact, in Russian Federation back in 2019, they were registered a unique treatment, tafamidis. So since then, we appreciated very active development of ATTR cardiomyopathy diagnosis development. So we appreciated many more publications. And currently, in our country, in Russia, we have excellent center for transthyretin cardiomyopathy. Let's look at the prevalence. Unfortunately, we do not have enough information about the incidence or prevalence of disease in our country because we never appreciated any large-scale observational studies, epidemiological studies, and definitely we mainly refer to the international data. But we fully understand that currently transthyretin cardiomyopathy is not something unique or casuistic. We know very well that patients with left ventricular hypertrophy and patients with increased blood pressure, approximately 13% of these patients finally could have transthyretin cardiomyopathy, which is confirmed later on. Now we can say that if it's heart failure with preserved ejection fraction, HFpEF, it's one of the reasons of this pathology, and it is transthyretin cardiomyopathy, which is in the basis of that. And according to different literature data, we know that approximately 17 patients with HFpEF can have transthyretin cardiomyopathy. Also, aortic stenosis, they say that about 16% of the patients have transthyretin cardiomyopathy. But as our experience shows, so this is not exactly what we see in our patients. So in our center, we carry out dedicated study on aortic stenosis in patients after TAVI. And I can say that from 50 patients with TAVI implantation, only one patient finally was confirmed as patients with transthyretin cardiomyopathy. But we should say how in real clinical practice doctors can just suspect that our patient has some risk or suspicion or probability of amyloid deposits. Definitely, we need to look at red flags, and surely this is left ventricular thickness, myocardial thickness should be more than 12 millimeters. And also number of the red flags, other symptoms and signs that we are guided by. And they show here the probability of presence of amyloid cardiomyopathy. And later on, it could be confirmed by diagnostic procedures. And this is what we have to do. This is myocardial scintigraphy and also biopsy-sparing diagnosis of cardiopathies. So what's the specificity of the treatment for this group of patients? We know very well that we cannot prescribe standard treatment for heart failure to the patients with ATTR cardiomyopathy. Beta adrenal blockers are not recommended. ACE inhibitors are not recommended, and now experts say more and more that the drug of choice for the treatment of this pathology could be treatment against heart failure, which is gliflozins. But definitely, we could never avoid targeted treatment prescription. And the only drug which is currently registered and available in Russia is tafamidis. And it was registered due to the pivotal clinical trials that today will be presented briefly by my colleagues. And at the end, we see positive outcomes of using this type of treatment. Well, definitely, today we need to have clear understanding that amyloidosis treatment is first and foremost multidisciplinary task. We have to establish a multidisciplinary team that is working together with the patients. So the first experience, this is experience of Mayo Clinic back in 2014, and currently around the world we appreciate more than 20 excellence centers, and these are all tertiary level clinics. So I'm showing this data very briefly because later on Professor Igor Žirov will speak more about our Russian experience on amyloidosis. So for very recent time, you see about 150 patients referred to us, and right now it's already more than 300 patients. So currently we identify about 50 patients with transthyretin cardiomyopathies, and more than half of these patients were eligible for treatment and they got tafamidis. So in other publications of our colleagues from Russia, it has been demonstrated that approximately 20% of patients of mature age group, 90 years or higher, mainly females, autopsy demonstrated presence of transthyretin cardiomyopathy. We in our center designed the algorithm and methodological guidelines how to screen and how to diagnose transthyretin cardiomyopathy. So this algorithm is shown here on the slide. Today, we say that we have to identify transthyretin cardiomyopathy very actively, and we have to carry out differential diagnosis. We have to understand the algorithms of early diagnosis of transthyretin cardiomyopathy, especially in patients with chronic heart failure. I already mentioned today that by now, the only treatment in Russia which is registered and could be prescribed for transthyretin cardiomyopathy is tafamidis. This treatment is very well known, and actually it is top 3 out of top 10 medical innovations of 2010. And you see, and one of the designers, Dr. Jeffrey, got award of breakthrough treatment, and also Wolf chemistry was given in 2023 to tafamidis. So in Russia, we have clinical guidelines for chronic heart failure, and there we have a dedicated section for the diagnosis and treatment of transthyretin cardiomyopathy. And in 2024, these guidelines have been approved by the Ministry of Health of the Russian Federation. We fully understand that tafamidis completely transforms the lives of the patients, prevents the progression of the disease due to unique mode of action. So, dear colleagues, that was very brief representation of the challenges we appreciate now, not only in our country, probably all over the world. And now it's my greatest pleasure to give the floor to our distinguished colleague, our friend, and our guest. And Fernando will speak about the learnings from European Cardiac Amyloidosis Center of Excellence, from suspicion to diagnosis and treatment. So, Fernando, please smile and start. You're on a big screen.
Well, Thank you very much for your kind introduction, Dr. Sergei Terещенко. It's a pleasure to share this session with you and with Professor Igor Shirov, too. So both professors, thank you very much for the invitation. I'm going to share my screen now.
Slides are on the screen. We can see it.
Okay. Gonna see if I can see them too. Okay. So the title of my talk is Learnings from European Cardiac Amyloidosis Center of Excellence from Suspicion to Diagnostics. So Professor Sergei Terещенко already talked about the importance of this disease and how in the last years we're able to diagnose more and more patients. These are my disclosures. So the first question is, why don't we diagnose ATTR cardiomyopathy more frequently? And until now, it was thought to be a very difficult diagnosis, and biopsies were needed for diagnosis too. It was thought to be a very rare condition, and also we didn't have any treatments, as Professor was saying before. However, now in 2025, we already have multiple diagnostic tools available. Even non-invasive diagnosis is possible for our patients. It is not so rare. We already know that it's not so rare, as Professor Terещенко was saying before. And also we have new treatments available for our patients. So how to suspect ATTR cardiomyopathy? First of all, we have all of our red flags. They have very simple ones, as the family history, the previous medical history, and the signs and symptoms of our patients. Also some signs in the ECG, as I will tell you after some slides, and also the echo, but also other more advanced imaging techniques like MRI. Scintigraphy is a very basic tool for the diagnosis, one of the most important tools for the diagnosis of our patient. And also, as I will tell you later on in the algorithm, genetic testing is needed to reach the final diagnosis of our patients. Still, in 2025, we need tissue studies, and also biopsies are important in some cases. And all of these are the real flags we need to diagnose our patient. So regarding TTR amyloidosis, you know we have an hereditary type and a wild type. And regarding the hereditary type, you know that we have the polyneuropathy, sensitive, and then motor in more advanced in clinical scenarios. We have the eye involvement in our patients, which is not that known, but these patients can have glaucoma and can have other important issues in ophthalmology. Also, the autonomic neuropathy, patients can have orthostatic hypotension, and also these gastrointestinal symptoms too that can be present. And as cardiologists, I mostly see cardiomyopathy. You know, this is hypertrophic cardiomyopathy with restrictive phenotype, and also patients need to have pacemakers many times. They have conduction system disorders. Regarding wild-type amyloidosis, we're diagnosing more and more patients, elderly patients with carpal tunnel syndrome, with this biceps tendon rupture, atraumatic rupture. We call the Popeye sign, as you can see here. And also, as Professor was talking about before, aortic stenosis. That is also very prevalent in patients with ATTR amyloidosis and aortic stenosis. And as I was talking about elderly patients with wild-type TTR amyloidosis, so is it really necessary to perform genetic testing in older patients with TTR amyloidosis? Well, to answer this question, we decided to perform a study some years ago in our hospital, and this was with 300 patients with TTR wild-type, we thought to be wild-type amyloidosis in more than elder patients of more than 70 years old, and 5% presented variants in TTR gene. So even though the patients were old, they still have mutations in the ATTR gene, especially in patients who were female. In that case, it was 10%, and those with a black ancestry or polyneuropathy. Most of the mutations were in the VAL142 ILE mutation and 26% in VAL50MET. So the answer to is it worth performing genetic testing in older patients? Our experience is that yes, it's worth it, because with this results, we can also assess the families of the patients. We don't have to forget about AL amyloidosis. Whenever we diagnose a patient with TTR, we have to discard AL amyloidosis. You know, the prognosis is even worse, and patients can evolve very rapidly, and it is a disease that can affect many organs, more heart, but also gastrointestinal, nervous system. And there are also some red flags like macroglossia or periorbital purpura, you can see in this slide. And we always have to discard this when we diagnose our patients. As you know, this is the classical ECG from a amyloidosis patient with very low voltages, but we've seen that this is not the most frequent sign in the ECG. It is around 33% of patients with wild type and 25% of patients with hereditary. However, atrial fibrillation is really common in these patients. This would be a more common ECG to find in patients with ATTR cardiomyopathy. You can see the pseudo-infarct pattern with the Q waves in the inferior and precordial leads, and this is in over 60% of patients with ATTR cardiomyopathy. So it doesn't have to be always with low voltages, but more with this pseudo-infarct pattern. What about the echo? This would be a very classical echo with a TTR cardiomyopathy patients. You can see the increased wall thickness, and you can see that it's all the walls are mostly the same width. It's like concentric hypertrophy, but we see in almost 1/4 of patients that they can also have asymmetric hypertrophy. This is a 4-chamber view. And here you can see also the sparkling of the myocardium, and then the mitral valve is also thickened. So that means that the deposits can be all over the heart, not only in the muscle, but also in the heart valves. The diastolic pattern is also very pathologic in these patients. They have this EA wave ratio of more than 2 with a restrictive filling pattern, and also very small Doppler velocities that you can see here too. What about more advanced techniques? You know that there's also a very typical strain pattern with the cherry on top, that the most apical segments are contracting better than the mid and basal segments. This is what we call the apical sparing pattern. And whenever we perform a MRI, we can confirm the findings from the echo, as with this increased wall thickness, large atria, but also with the MRI, we can assess the tissue, and we can see the late gadolinium enhancement. It was thought to be the most typical pattern was thought to be subendocardial LGE, but now we know that the most common is transmural LGE, and it's very rare to find patients with no LGE, but that this can be found in earlier stages of disease. So if we have to take home like 2 main messages, it would be mainly transmural and global subendocardial, the patterns we see in this MRIs. Also, we can perform more advanced techniques in the MRI with T1 and T2 values and extracellular volume, and we see that patients with amyloidosis had very extreme values, very increased values of T1, and very increased values also of extracellular volume. That's also a hint for the diagnosis of amyloidosis in our patients. So this is from the European consensus that was published some years ago already, and we know that whenever we have the wall thicknesses more than 12, and one or more of this clinical or findings that we can see in other tests, we should suspect amyloidosis. This can be heart failure in over 65 years old, aortic stenosis, hypotension in patients that were previously hypertensive, and also some other features like bilateral carpal tunnel syndrome or the ruptured biceps tendon, the Popeye sign I was saying before. Very important, scintigraphy. Scintigraphy, you know, this is a technique that we have been using for years, but in the 80s, we already saw that in these bone scintigraphies, patients with cardiac amyloidosis has had this very increased uptake in the heart. This was a test that is normally performed by rheumatologists, by oncologists to see the bone affections, but you already know that there is an increased uptake in patients with TTR amyloidosis. These are the different grades we can see in the scintigraphy. From 0, you can see no uptake in the heart. Grade 1, an uptake that is less than the bone. Grade 2 is similar uptake in the bone and in the heart. And grade 3, a very, very increased uptake in the heart, even higher than in the bone. But it's very important to say that although it is more specific for ATTR cardiomyopathy, we can also see it in AL amyloidosis. 30% of cases had a grade 1 uptake and 10% of cases have a grade 2 uptake. So we always need to discard AL amyloidosis whenever we are assessing a patient for TTR amyloidosis. The biological tests we need to perform, there should be 3 tests: the serum free light chain quantification and then serum and urine immunofixation. We already know that this kappa lambda ratio can be abnormal in patients with renal disease. So in patients with a renal function, for instance, glomerular filtration rate under 30, the ratio can be up to 3, whereas in patients with more normal the renal function, it should be around from 0.4 till 2. So this is something we need to look when we are assessing our patients. Also, it's very important to say that scintigraphy can have false positives. We can have patients without TTR amyloidosis with a positive scintigraphy. I already mentioned AL amyloidosis that can be positive in the scintigraphy and requires an histological confirmation, so biopsy, but also some other patients, for instance, with hydroxychloroquine toxicity, can also have a positive scintigraphy. These are patients, for example, with lupus that have been treated with hydroxychloroquine, and also some more rare types of amyloidosis like ApoA1, ApoA2, ApoA4. And then these patients have more kidney disease present, a very rare type of amyloidosis that can also have the positive scintigraphy. It is also important to use SPECT. This is a 3D image, because otherwise, if we just use normal scintigraphy, we might be assessing the blood pool, not the cardiac tissue. And this is very important to perform always the SPECT. Also, rib fractures or annular calcifications in the valves can have uptake in the scintigraphy. So that's why we need to use SPECT. And also patients with an infarct, with a heart attack in the last 4 weeks can also have a positive scintigraphy. And regarding false negatives, some mutations you can see here can have a false negative in the scintigraphy, and also very mild disease. Patients that are starting with the disease can have a negative scintigraphy, and these cases require the histological confirmation. And also more technical issues. Scintigraphies need to be performed by nuclear cardiology specialists that really know about this technique, because otherwise, with delayed acquisitions or premature acquisitions of images, we can have false negative results. So after all these tests, I would like to show you the algorithm that has been published in the European Heart Journal and that we normally use in our clinic. So in all the patients where we suspect TTR cardiomyopathy because of the ECG, echo, and MRI, we always perform these 2 tests. So the hematological study and also the scintigraphy. Here we can have 4 clinical scenarios. Both tests negative. In this case, AL and TTR are very, very unlikely. And if we are thinking about more rare cases of amyloidosis, we should perform MRI if it hasn't been performed before, or the biopsy, heart biopsy, to see if the patient has amyloidosis. When we have a negative hematological study and a positive scintigraphy, then if this is positive with 2, 3 grade, we have already the diagnosis. And we have to perform genetic testing to see if it's wild type or hereditary TTR amyloidosis. In case of a positive scintigraphy with just grade 1, we need to confirm also with biopsy, because this could be a false negative of a false positive of the test. Then we can have the positive results from the hematological study with a negative scintigraphy. In these cases, we almost always need a biopsy, but if we perform an MRI, if this is negative, amyloidosis is unlikely. But when we suspect AL amyloidosis, this is a medical emergency. We need to run in order to have the diagnosis soon to start treatment. So in these cases, we normally need to perform a biopsy to see if the patient has AL amyloidosis. And in some cases, we have both tests positive, and we need to perform also a biopsy to subtype to see if the patient has an AL amyloidosis with a false positive scintigraphy, if the patient has an ATTR amyloidosis with just some abnormalities in the hematological test without clinical significance, or if the patient has the 2 diseases. This is very rare, but we have seen that in the clinic too. And whenever we have to perform a biopsy in our center, as it is an advanced heart failure center with heart transplant, our cardiologists, from the cath lab, they perform biopsies. And this is what we see. We see all this tissue without nuclei, the amyloid deposits, and then the cardiomyocytes. Whenever we want to confirm if there's amyloid, we need to use the Congo red staining, and under the polarized microscopy, we can see this green with bearing fringings. If we want to know the type of amyloid, we need to perform immunohistochemistry with TTR, kappa, lambda, and AA antibodies. And if still we don't have the diagnosis, we need to perform proteomics, mass spectrometry, or even immunoelectron microscopy. And then we will have the definite diagnosis. Now, I would like to talk to you about some other comorbidities. Professor Terещенко was talking before about aortic stenosis and heart failure with preserved ejection fraction. We know that this is very frequent in patients with amyloidosis. In patients with HEP-PEF, 13% of patients, between 13 and 17% of patients have an underlying amyloidosis. And regarding aortic stenosis, that is around 8% of patients who undergo TAVI have an underlying amyloidosis. This also applies for conduction disorders, 7.6% have amyloidosis, and also in patients who undergo scintigraphy for other reasons, we can find incidental diagnosis in 0.5% of cases. And in cases of hypertrophic cardiomyopathy, 12%. This is a study that was performed in our center 10 years ago, 120 patients over 60 with HEP-PEF and an increased wall thickness of more than 12. We found that 13% of patients had ATTR wild-type cardiomyopathy. This is consistent with some other studies that were published after. In this case, this is from the outpatient heart failure with preserved ejection fraction patients. And in this case, it was 6% of patients with the diagnosis. We also know that in patients with what we thought to be other diagnoses like hypertensive cardiomyopathy, in the end, they had amyloidosis. So how can we know the difference between hypertension and amyloidosis? Where in amyloidosis, we normally find a right-sided heart failure. The increased wall thickness is very disproportionate, and we sometimes need to discontinue or reduce the dose of the antihypertension therapy in these patients with amyloidosis. And regarding patients undergoing TAVI, there are some studies that almost 16% of patients had an underlying ATTR wild-type amyloidosis. We know that patients that undergo TAVI and have an amyloidosis the TAVI also improves prognosis in these patients. So we really need to think about TAVI in these patients because we can offer them not only the valve, but also treatment after with tafamidis, for instance. So this is important to bear in mind that patients with amyloidosis should also undergo TAVI. If we see the prognosis of patients with undergoing TAVI with and without amyloidosis, there are no difference in mortality between both patients and ATTR, but however, ATTR has more rates of heart failure over 1 year. So we really need to follow up these patients more frequently. How to distinguish patients with aortic stenosis, with underlying amyloid, to those without underlying amyloidosis. We know that patients with amyloidosis are a bit older, that the quality of life is worse in patients with that had also amyloidosis, less hypertrophy in the ECG, and the wall thickness is a bit more increased than in the lone aortic stenosis patients. Regarding, I was saying before that in patients with amyloidosis, they had an increased risk of conduction disorders. But however, in the guidelines, we don't have different, at least in the European guidelines, we don't have different indications for pacemakers in patients with amyloidosis. However, we know that patients with amyloidosis have an increased risk of pacemaker implantation, and there are some papers that have described that the history of atrial fibrillation, the prolonged PR interval, or an enlarged QRS are predictors for receiving a pacemaker in the following months. Also, increased wall thickness and the QRS duration was related to an increased pacemaker implantation risk at 12 months in this paper. So we know that with amyloid, we already know how to diagnose it, and the patients have a lot of comorbidities, as I was saying in the last slides. And we also know that it's very important to have a multidisciplinary teamwork in patients with cardiac amyloid. Why? Why is this important? Because there is a constellation of symptoms. Patients can have cardiovascular symptoms, but also sensitive symptoms, the central nervous system symptoms. So it's important to have other specialists to help us with diagnosis. We know that in the last year, the patient's diagnosis has been delayed because sometimes more than 5 physicians are needed in order to diagnose these patients. This is something that we need to change because as we spend more time to diagnose the patient, then the life expectancy gets worse and worse. And also, the quality of life gets worse whenever we spend more time until we diagnose the patients. However, we are getting better. Here we can see data from the UK, and we can see in the NAC stage, the National Amyloid Center stage at different years. And in the last years, we're diagnosing patients at stage 1 more frequently. And this is always it's already a good news because if we start treatments better, the patients will do better. And we know that teamwork matters because also in this work that was published 3 years ago, we know that in patients that were diagnosed in the last years, we're diagnosed more frequently in NYHA class 1 or 2. The diagnostic delay less than 12 months is more frequent in the last year. The stage of the disease is at 1 or 2 stage is more frequent in the last year, and patients are more referred to cardiologists. So this is already good news. Things are changing in our patients. Most of this, the reasons for this change is that now we have treatments, and we have treatments at different levels. As in Russia, in Spain, we already have commercialized tafamidis. We don't have any other drug commercialized yet, and that's a stabilizer of TTR. But we know that we have some other drugs coming as the suppressors, like the gene silencers, and also removers, like the antibodies. So we have a lot of ways of treating our patients and to change their prognosis. I also was told to talk about our experience at our hospital, at Pουέρta-de-Yerro Hospital here in Madrid. And I would like you to show some slides to explain how we are organized here in our hospital. This is just for you to see what's the evolution of the diagnosis of amyloid in our center. If we go back to 2010, there were over 1 year, only 3 patients diagnosed with ATTR and 3 patients with AL amyloidosis. And for instance, last year, almost 100 patients were diagnosed and more than 100 in the previous years and 9 with AL. So you can see the great increase in the diagnosis because we are more and more thinking about red flags in our patients. Also, we have participated in different clinical trials before 2020, we participated in the TRACS trial that was with the families that were published already in 2018. And then later on, we've been also participating in trials with acoramidis, patisiran, and also antibodies. This is our team at the hospital, our chief, Dr. Paulo Garcia Pavia. Then we have 2 other more consultant cardiologists, myself and Dr. Esther Gonzalez Lopez, our doctors from the heart failure unit, also neurologists, our nurses, study coordinators, and also doctors from other specialties. We have nephrologists, we have ophthalmologists, hematologists, pathologists, and rheumatologists. So this is very important in order to have this multidisciplinary approach for our patients. After seeing all these patients, we have the honor to have published papers in different journals because of the increased experience we're gaining with these patients. And we have mainly 2 teams. We have the AL team and the ATTR team. I belong to the ATTR team with the heart failure and inherited cardiac disease unit, and the AL team are our colleagues from the heart transplant group. And then we have all the specialists working together with us. Hematology, nephrology, ophthalmology, genetics, pathology, and also sometimes proteomics when we need to perform mass spectrometry, and of course, neurology. So how do we evaluate the patient? After an initial evaluation, either in the AL or the ATTR team, we decide to send our patients to nephrology, neurology, and in order to start treatment. And how are we organized? Well, we have easy contact between professionals in the web or with emails. Whenever a patient is sent to our hospital, we perform tests before the clinic, so echo and ECG and even MRI. So because time matters and we need to perform tests as soon as possible. When we think about AL, we need to prioritize these cases because we need the diagnosis as soon as possible. There's a fluid contact between specialties, even with WhatsApp, with the mobile phone. And we also are always available for clinical trials with other colleagues too. We have supporting from the cardiology department with other study coordinators. And this is like a multidisciplinary approach where everything works. We have a lot of communication between the different groups. Also, for patients, there is an easy access on the phone. We have a secretary who responds to the phone whenever the patients have any doubts, and also an email. Here in this email, some other colleagues, other cardiologists from other hospital can send us their doubts, or whenever they want to refer a patient to our hospital, we have a specialized email just for that. And before the clinic, we review every case by the staff cardiologist. In the same visit, they come to the hospital, we perform all the tests. So the same day, they will get the echo, the ECG, scintigraphy, and the blood test in order to in order to take advantage of time as much as possible. And regarding the clinical arrangement, we always assign a family number for the patients with hereditary cardiomyopathy so that we have the same number whenever we also assess their families. We have family trees, and we also collect where we can collect all the clinical info. And after the clinic, we always have a team meeting with case discussion to see how the patient are progressing. We also organize the next appointments for the patients. We can see if the patients can start on clinical trials, and we can also introduce all the data in the unit's database. So, and how do we select the patients for specific treatments? We only have, apart from clinical trials, we just have tafamidis commercialized. And I suppose that in Russia, you have also the same problem. We need to select very well these patients. Here you can see the mean age of our wild type patients and the mean age of the hereditary patients, almost 80 for the wild type, almost 66 for the hereditary. And we always think about the disease stage and also about the comorbidities and frailty. Regarding frailty, we also ask our geriatric colleagues from geriatrics, because this is very important in order when we want to start the treatment, because very frail patients, we actually don't think that it's worth it starting on treatment. So how do we select specific therapies? We always choose patients that have a predicted survival of more than 1 year, a frailty score less than 5, and if the patient is over 80, they should already have heart failure, not asymptomatic patients. So this was my last slide. So thank you very much for your attention, and now I'm happy to solve all your doubts and your questions.
Спасибо большое, профессор
Thank you very
Домингес.
much, Fernando. You can stop sharing. Thank you very much, Professor Dominguez, for fantastic presentation. You covered the work of your excellence center, and I have a question to ask. What is the percentage of tafamidis prescription in your center? So, in percentage, how many patients get tafamidis?
Okay, from all the patients who get diagnosed, I would say that perhaps like 40% of patients, because those that are too old don't get into tafamidis or have many comorbidities, and some other patients also come from other regions in Spain, because I don't know in Russia, but in here, the patient needs to be from a certain region in order to have tafamidis. So patients from Madrid receive tafamidis from Madrid. Persons from Barcelona receive tafamidis from Barcelona. So this is like very well organized now. But I would say like 40%.
Спасибо большое.
Thank you very much. I have another question. You tackled a very interesting topic, which is combination of AL and TTR amyloidosis. You said that these situations are extremely rare, casuistics, but still, have you ever seen such patients? How many? Because we had such patients in our center. Well, according to different literature data, specifically American colleagues say that it could be up to 10%, but in your practice, could you please speak up?
I would say there's not 10%, perhaps 5% of patients. It would be like more real life, because perhaps some data from literature and also from very experienced centers where all the most complex cases are sent. So I would say that's something that we can see in 5% of cases. And these are very challenging cases because we need to treat for both diseases. So here we normally prioritize AL amyloidosis because it's more severe. So the patients start receiving treatment for AL, and whenever the patient's stable, then we think afterwards about the TTR treatment.
Спасибо большое. У меня еще один вопрос.
Thank you very
потом
much.
попрошу
I have another
Виталия,
question,
если
and then
вы
we give the floor
задать.
to my colleague. Maybe he will
Я
ask some
хотел
questions.
поговорить по поводу
If
больных
possible,
с
I would
аортальным
like to
стенозом.
get your
В тех
position about patients with
рекомендациях, которые мы
aortic
видим,
stenosis.
на
In the
кого надо
guidelines,
обращать внимание?
we see who we should pay attention
Утолщение
to.
стенок левого
Thickening of left
желудочно-кишечного
ventricular wall more than 12.
артериального
Yes, we know,
стеноза.
but in case of
Естественно, там
aortic stenosis,
значительно
naturally, that
больше
would
утолщения.
be
Вот
much
вопрос.
bigger thickening.
Для них
So, the
толщина
question, what do you
миокарда
think for
должна
aortic
оставаться
stenosis
12
patients?
или
Threshold is
есть
still 12.
какие-то здесь
Or
нюансы,
maybe there are
другие
some nuances
красные
and
флаги?
maybe
Вот второй
other
есть
additional red
определенная
flags,
нюансы именно у больных с аортальным
specifically
стенозом,
for
именно
aortic
больных,
stenosis,
которые имплантируются
the patients
TAVI.
also who are implanted TAVI. Thank you.
Yeah, very good question. It's true that patients with aortic stenosis already have hypertrophy, but here normally we see patients with a disproportionate hypertrophy, so perhaps more than 15, more than 16. Also, in patients with aortic stenosis, it's not typical to have an ECG with low voltages or with a pseudo-infarct pattern. So the ECG is also important in patients with aortic stenosis because that's also can be an important red flag. And also, I think that right-sided heart failure is also a red flag because for aortic stenosis, more patients have pulmonary congestion, angina, syncope, but patients with additional ATTR cardiomyopathy, they also can have more edema and more right-sided heart failure.
Все-таки не могу не задать вопрос, Игорь
Well,
Витальевич, вы меня извините.
I still need to ask this question, Igor. I'm sorry. Another question. I want to ask about patients with terminal heart failure, terminal HF. Do you think heart transplantation is possible in this category of patients? I'm sorry, this is out of topic question.
Yeah, well, regarding TTR cardiomyopathy, patients are usually quite old. So in Spain, it's very unusual to have a heart transplant over 70. So those patients with ATTR should be very selected cases regarding wild type and in patients with a very early diagnosis. That could be done. And patients with hereditary cardiomyopathy, ATTR, those should be patients that aren't very sick regarding the neurology part of the disease, because otherwise heart transplant could help, but then wouldn't help if they're already very sick with neurological symptoms. So I would say that yes, but very selected cases. And in case of AL, amyloidosis, we need to have the hematological disease controlled before. So these patients are given the chemotherapy, the treatment for AL, and if they manage to control that, then they can be assessed for heart transplant. But again, I have to say this is very, very selected. Regarding TTR, it's very, very selected cases.
Спасибо большое, Игорь Витальевич. У вас
Thank you very
есть
much.
вопросы?
Igor, do you have any questions? Yes, dear Fernando. Thank you very much for a fantastic presentation. I have two questions to ask. My first question, please tell us, how do you treat heart failure in patients with amyloidosis? Any nuances, any special, let's say, treatments? Thank you.
Yeah, very, very nice question. So we know that the background therapy for heart failure in amyloid patients have some nuances. For instance, beta blockers, we don't like them, as Professor Terещенko said before too, because lowering too much the heart rate doesn't work properly for these patients, and they have more increased risk of conduction system disorders. We also have to be very careful with the excess of diuretics. We have to keep the patients euvolemic, but not too dehydrated, because they can have renal disease in those cases. And also regarding patients with lower ejection fraction, we normally use ICGL2 inhibitors, but they are pretty safe. But we still don't know the role of the ARNI, for instance, of sacubitril/valsartan. We still don't know the role of those drugs. Beta blockers, we don't use them, as said before. And then to control heart rate in atrial fibrillation, we prefer normally either amiodarone, even for rate control, rhythm control, but also for rate control. Avoid beta blockers or very low doses, and precaution with digoxin. You know that these patients can get intoxicated more easily, so very careful with digoxin. Although we see that in some patients we cannot control heart rate, it can be used with a lot of caution. With very low doses, we use them in some patients. And calcium channel blockers are contraindicated.
Спасибо. И еще вот вопрос.
Thank you very
такой,
much.
может быть, как блиц, вопрос.
Another question,
Скольким
very short
процентам
question.
больных вы
To what
делаете
percentage
заключение
of the
операции?
patients do you
Скольким
perform
процентам
myocardial
больных вы
biopsy, and to what
делаете
percentage of the
заключение?
patients do you perform mass spectrometry?
Okay, so myocardial biopsy, when we already have this non-invasive disease, but also in patients who are old, hematological tests can be also abnormal. So I would say that 30% of patients, like 30% of patients, are still undergoing endomyocardial biopsy, and the percentage of patients that are going to mass spectrometry inside that 30%, it's getting lower and lower because the antibodies we have the hospital getting better. So I would say it's like 15% of that 30%.
Спасибо большое, профессор
Thank you very
Домингес. У меня
much.
всё-таки
Thank you
ещё
very much, Professor Dominguez. But I have another question. Very provocative, very provocative. Familial transthyretin cardiomyopathy. Let's say father has some cardiomyopathy and you see heart failure, which is progressing. But in his children, we confirm it genetically, but yet no signs and symptoms, nothing. The question is, in this situation, do we have to prescribe tafamidis to his son preventively, like prophylaxis, with possible development of cardiomyopathy is pretty high, the probability is high. What do you think, and what do you do?
Yeah, thank you for that question. It's very relevant, and I think that that's the future. We don't know yet if it's useful or not, but we have ongoing clinical trials. There is a clinical trial that we are participating here in our center, and it's called ACT Early, and it is in carriers of TTR mutations. We start preventively with acoramidis in this case. And it's going to be a very long trial because we need to wait long time to see if the disease is going to be there. It's going to be almost like 8 to 10 years of follow-up. But that would give us the answer to your very important question. We don't really know yet, but I think that perhaps in the future that would be how we are going to treat patients. Yeah.
Спасибо большое, Игорь Витальевич. Вопросы в чате.
Thank you very much. Please check the chat. Yes, we have question in the chat. At what stage of the disease do you prescribe tafamidis in Spain? Are these patients with already, let's say, extended clinical picture advanced, or maybe the patients with a very early diagnosis?
Okay, so thank you for this question. Where the indications for tafamidis in Spain is you need to have over 600 of NT-proBNP. But so in some patients that are not very symptomatic but already have more than 600, that can be prescribed. In less than 600, we don't have the indication yet. And it's normally is NYHA2 over NYHA2. So although some patients with earlier stages with NYHA1 but over 600 NT-proBNP can start already with treatment.
Спасибо. И у нас один вопрос в чате.
Thank you very much. And we have another question in the chat. Please advise, in case of diagnosed transthyretin amyloidosis, and patient is getting treatment. But beside the treatment, the disease is still progressing. Heart failure is progressing. Do you think we have to discontinue, or still this treatment, let's say, mitigates the aggressiveness of the disease? What do you do in such cases, and how do you monitor them?
Okay, so whenever we start tafamidis, we see the patient every 6 months, and we perform ECG and blood test every 6 months, and then echo once a year and Holter ECG once a year. We know that this is a stabilizer, so we don't expect the patients to get much better, but to get stabilized, to get controlled. So to make the decision of discontinuing the drug, we need, if a patient starts getting inpatient, they have to get it admitted for heart failure in multiple times, or in those cases, we sometimes think about discontinuing. Of if the patients have another comorbidities and are already very old with other comorbidities, we'll always also discontinue in those cases.
И заключительный вопрос наших коллег.
Another question from the chat, maybe final, again about the diagnosis of amyloidosis in aortic stenosis patients. So, dear Professor Dominges, could you please speak up once again, which are criteria of amyloidosis diagnosis in aortic stenosis patients we have to use? Diagnostic criteria in case of aortic stenosis. Please explain once again. Maybe you have a slide on that.
Yeah. Well, so diagnostic criteria is the same as uptake of 2 or 3 and the Perugini score and the scintigraphy, and with negative hematological tests. When to perform this screening in the patients, I would say that whenever we have one additional red flag, so not only more than 12 millimeters of thickness, but also an abnormal ECG, right-sided heart failure, patients that have a very high levels of NT-proBNP, like disproportionate levels of NT-proBNP, those are the ones we should screen for amyloidosis. However, we are screening more and more patients with scintigraphy. If you think about it, most patients who go to TAVI, we perform a CT scan to see the annulus and to see the aortic valve. So in these cases, it's not difficult to perform a scintigraphy too. So I would screen most of patients, but especially those with perhaps more than 14, 15 millimeters, right-sided heart failure, and very high levels of NT-proBNP.
Спасибо большое, глубоко уважаемый
Thank you very
профессор
much.
Домингес.
Thank you, dear Professor Dominguez. Thank you for sharing your very valuable experience. In fact, definitely, we have so many open questions, but unfortunately, our time is limited. So once again, we would like to thank you, and we do hope that the experience you are sharing today would be very useful for us for our work. And now, dear colleagues, let me give the floor to Professor Igor Жиров, and he will be sharing the results of 3-year work of our Excellence Center on Transthyretin cardiomyopathy. The floor is yours. You can stop sharing, Professor Domingues, and then you can see them better. Thank you very much, dear Sergey. Thank you very much, dear Fernando, for the opportunity to share experience of our Excellence Center of Amyloidosis. It's somewhere on the top. Stop sharing. Red button, probably. And we represent a cardiology institution named after Chazov, and we are the only approved by the Ministry of Health Excellence Center on Amyloidosis. And our main task is the diagnosis and prescription of specific treatment to patients with amyloidosis. My presentation is also supported by Pfizer company. Here you see a logo of our center, and I'm extremely grateful to all our team, all our colleagues who have been helping with making these slides, and actually due to them, today we can enjoy these results. So this is Svetlana Nasonova, Marina Saidova, Dr. Sergeyenko, Alexey Anshelis, Sergey Chernovoy, Mira Pasharia, and all those actually who participated. And this is a very long list. If I name all of them, it will take all my time for the presentation. But still, dear colleagues, we are happy to show you preliminary 2-year results, and we published them. And specifically, this is a publication in Therapeutical Archives, peer-reviewed journal, and you can see there all colleagues who participated in our activities. So, by June 2025, you can appreciate here the dynamics of how many patients are coming in different years. And you see channels where they're coming from. So from the very beginning, it was very clear that majority of the patients, that was actually initiatives of the patients themselves, so patients on their own. But now we see that distinguished colleagues from different regions of our country refer these patients to us for the consultation. So referral from different centers. The question is, and how many patients with other different diagnoses we see? And specifically about cardiac amyloidosis, since then, since these 3 years, we consulted 380 patients, and from them, amyloid cardiomyopathy of any type was found in 120 patients. So that means every third from those who was referred, every third. What are other diagnoses? They were already mentioned by Sergey, by Fernando, and these are exactly the conditions that manifest with myocardial hypertrophy and other symptoms which were already discussed in the first and in the second presentation. Mean age of the patients with already established amyloid cardiomyopathy. You can appreciate, dear colleagues, well, this age is approaching, well, almost the beginning of pension. This is age 66 in median. So once again, I'm saying that these are those patients where cardiac amyloidosis was found out. So we don't see the same number of elderly or frail patients like in international publications, but at the same time, we see pretty many patients of still employed age, employed patients, but with already established diagnosis. So the type of amyloid cardiomyopathy, or majority of the patients, just like Professor Domingues mentioned in his slides, so these are patients with AL amyloidosis. Yes, a bit more than half, but you can appreciate, dear colleagues, here that more than 45% of this 120, these are patients with transthyretin amyloidosis with different forms, variant or wild type, and actually it gives us a pretty serious amount. So 55% AL and 45% ATTR, and you can see this distribution on these pie charts. So this is one very unfavorable information which was already discussed. So the median time from the onset of clinical symptoms up to the diagnosis. So diagnostic journey, how long is it? How long is it? Well, thank goodness we see that for AL amyloidosis, it's 1 year. And yes, you are right. This type of amyloidosis requires emergency. But wild type, this is column 3, 4 years from the onset of symptoms up to diagnosis. 4 years patient's journey. So for these 4 years, patients come to 5 different specialists, and this is exactly what was said before: gastroenterologists, ophthalmologists, neurologists, nephrologists. So all that is telling us that regardless of serious achievements here, but still the awareness about cardioamyloidosis still requires further improvement. What are the reasons of late diagnosis? Well, a low level of awareness, many masks of the disease, systemic type of the disease, and the most important, the absence of the only pathognomic feature by ECG or other visualizing methods that would say for sure that our patient has cardiac amyloidosis. What are the symptoms in disease manifestation? So once again, let me draw your attention to the fact that we are cardiology center, and that is why we have some professional deformity. So we can presume that majority of the patients that are coming to us should have some cardiological symptoms. But please appreciate, look at this data. We had patients who had never ever any changes of cardiovascular system, but in 20% it was, let's say, monoform, neurological form. And in all these patients, we confirmed transthyretin amyloidosis. In 5 cases, we did not see any changes of cardiovascular system, but we saw significant changes of kidneys, renal patients, and these are definitely patients with systemic AL amyloidosis. So prevailing manifestations, heart failure, majority of the patients with AL amyloidosis, and I draw your attention to that. But not all patients, not all with transthyretin, not all. Why? Because the progression of the heart failure speaks about very advanced type of the disease. And in fact, we have to make diagnosis of cardiac amyloidosis when these patients do not yet have features of heart failure. Laboratory markers, they have already been mentioned today. So very high levels of NT-proBNP, minimal 1832 picogram per milliliter, maximum almost 9,000. So in some of these patients, well, approximately 40% did not have any clinical signs and symptoms of heart failure, but at the same time, they had very high markers. So that means markers and these parameters are to be used as red flags to increase suspicion and to increase awareness. Well, the features of amyloidosis that were found out, well, during examination, they were mentioned. Cherry on top and specific deformities in speckle tracking, apical sparing, and paresis of middle and basal segments, specific changes on ECG. And once again, dear colleagues, I would like to repeat it. This is not only the low voltage, also pseudo-infarction pattern, which was spoken about today, also deterioration of conductivity, also restrictive pattern in echocardiography. So this is all that which has already been mentioned in very detail in first 2 presentations. Well, the algorithm of long-term monitoring and long-term follow-up, what are the news here? Well, we in our center use scintigraphy with osteotropic radiopharmaceuticals, not only as diagnostic tool, we also use it also for the assessment of the efficacy of treatment we carry out. And the results of our publications are shown here, and dear colleagues, you can appreciate them in peer-reviewed journals. And in fact, we can say that truly the use of scintigraphy allows to identify the reduction of pathological protein accumulation in myocardium. Now, treatment. When we speak about specific treatment, we're mainly based on some guidelines and recommendations. Well, we have recommendations of Eurasian Association of Cardiologists and also National Society to Study Heart Failure. We also have national clinical guidelines approved by the Ministry of Health of the Russian Federation, and the only targeted treatment which is approved and allowed to be used in cardio amyloidosis is tafamidis. And dear colleagues, we showed that using this series of scintigraphies, we proved that tafamidis reduces the absorption of radiopharmaceuticals in patients in heart, in patients in transthyretin cardiomyopathy. And then it gives us opportunity to have some optimism for the future, because we see that increase of suspicion rate in primary medical chains leads to the fact that patients are referred to us at potentially early stages, and the prescription of such treatment may dramatically improve the clinical condition of the patients and their prognosis. Dear colleagues, so summing up our achievements in the time given, let me once again to wrap up and express gratitude to all those colleagues, mainly colleagues from myocardial diseases unit, that is led by Professor Terещенко and also colleagues from other units and wards, and with their efforts, we are happy to share the results of our work. Thank you very much. And this is our final slide. So if you have interest or desire, I recommend you to take a picture of that, because this is our contact information. So that's the best excellence center for amyloidosis in Russia, in Moscow. This is a way how you can refer your patients to us for the diagnosis, full treatment. It could be face-to-face consultation, it could be telemedical consultation. And with that, thank you very much. Igor, thank you very much for a very interesting presentation. Well, we really, looking back, understand that quite a lot was done. So many patients were diagnosed with different cardiomyopathies, AL amyloidosis and transthyretin amyloidosis. And I have a question to you, Igor. Could you please elaborate a little bit more details about the prescription of drugs for the treatment of heart failure in patients with amyloid cardiopathy? Well, Fernando already spoke about it, but let's try to compare, because he spoke about what is not allowed, but what is allowed. So he spoke about don'ts, but let's speak about do's. What is possible? How should we treat heart failure? Thank you. Well, dear Sergey, dear Fernando, I would put it this way. The most important aspects for the management of patients with cardiac amyloidosis and heart failure, and this is the approach we use in our center, is the use of the treatments which are not leading to the development of the small ejection syndrome. What do we use? SGLT2 inhibitors, gliflozins, and we also carry out a study in our departments about the efficacy of using one of such treatments, dapagliflozin, and the study is registered on clinicaltrials.org. And already in the near future, we will come to the statistical processing of the results. I can give you a little bit of spoiler. Well, results are positive. Results are positive. Also, we use mineralocorticoid receptor antagonists, MRAs, and we are trying to avoid, as Fernando said, beta adrenal blockers, Norway. Our experience in particular tells us that in our sampling of the patients, the using of drugs influencing renin, angiotensin, aldosterone normally tolerated very poorly by our patients, RAS inhibitors. So if you prescribe something, then doses are very far from targeted doses, so minimal doses. And definitely, we almost don't use glycosides, cardiac glycosides, or if we need some bradycarding treatment in case of atrial fibrillation, we do it just like our Spanish colleagues. As a drug of choice, we use amiodarone. Yes. Thank you very much, Igor. And it's very tempting to ask you a question which was asked to our distinguished colleague from Spain. How frequently, your percentage of tafamidis prescription, and which criteria? Well, criteria for tafamidis prescription presented in detail in those two documents which I referred to in my presentation. So these are recommendations of Eurasian Association of Cardiologists and Society to Study Heart Failure and national guidelines on chronic heart failure, where we have dedicated amyloidosis block. It's a separate chapter. According to these recommendations, according to these guidelines, patients with cardiac amyloidosis and chronic heart failure, starting from very early stages, we have very clear indications to use targeted treatment, specifically tafamidis. But let me put it this way. For example, there is a situation, and there is a patient referred from neurologist, and they already prescribed 20 milligram of tafamidis because of polyneuropathy. And then later, you find out heart failure. What is next? Well, you're right. Yes, we have such patients, and we're closely cooperating with our colleagues from National Neurology Center. This is center of Professor Suponeva. So in that case, If patient has diagnosis of amyloid polyneuropathy, and if the patient is getting 20 milligram tafamidis, and we see disease of cardiovascular system, then our recommendation to increase the dose up to 61 milligram, from 20 to 61. And let me add on, coming back to your previous question, prescription rate of tafamidis, I have to say that from those who have diagnosed transthyretin amyloidosis, we normally have medical consiliums, and majority of our patients, I think 70% from diagnosed pool, 70. But how many of them are getting drug in reality? That's another question, because the issue of reimbursement is challenging, because we know that not many of those who were recommended are taking the drug. Not everyone gets it reimbursed. Another question about red flags. Well, Professor Dominges already spoke about it, but maybe we have some extra red flags, let's say extra red flags that we have to pay attention to. Well, scarlet flags, yes, scarlet flags, yes, super red, because you see 65 years, well, it's not a red flag. We have so many people of 65, you know, it's not exactly like this. So maybe we have some specific symptoms here, maybe some moments we have to be very cautious. Well, thank you very much for that. From our point of view, to say that, let's say, thickening of the wall more than 12 millimeters, well, I think it's too optimistic to call it a red flag, because normally we call it a red flag when there is, let's say, more significant thickening. But if we speak about super red flags, let's say it's thickness of the right ventricular wall, If it's more than 6 millimeters, then this patient deserves specific screening for the presence of any infiltrative disease. Or it can be a situation when we see that patient has dramatically thickened walls of the left part of the heart symmetrically, but still there is moderate pericardial effusion, The situation where patients without severe features of heart failure, but still there is very high NT-proBNP, which Fernando mentioned, and the situation when we see the combination of cardiological and other symptoms from other organs and systems. So it could be, let's say, clinics, when it's accumulation, totality of several, let's say, signs and symptoms, then the probability of cardiac amyloidosis is dramatically increased. Thank you very much. Igor, you showed that actually we have very high percentage of IL amyloidosis, 55%. But cardiology centers like Chazovsky Center are not dealing with hematology and chemotherapy. So how do you interact with different specialties with hematologists, because you don't have hematology wards? So, for example, patient is diagnosed AL amyloidosis, and what do you do? What is the next step for the patients? Because patients come from different regions, and we can diagnose them. And what do we do next? Do we refer them back to the regions, or we have some interaction, let's say, with our distinguished hematologists? Well, thank you very much. As you know, we are federal level cardiology center. We are tertiary center, excellence center. And you are right. Majority of the patients that are referred to us are regional patients from the regions. And we have legal contracts, and also we have very good friendly relations with our colleagues with the similar Federal Center of Hematology. They have specialized wards, specialist department that is treating paraproteinemias, and they are dealing with the pathology that is in the focus today, AL amyloidosis, and we also have our own AL team in the other federal institution. So if we see IL case, then we refer to other federal center, hematology center, and they carry out more topical diagnosis, and then they hospitalized or refer this patient somewhere in order to get specific anti-AL treatment. And I totally agree with Sergey and with Fernando that if we suspect AL amyloidosis, then it requires very aggressive treatment, because prognosis without specific treatment is extremely unfavorable. Igor, please advise. If we have a combination, although it's very rare, you're right, and we already asked about it, but still it's relevant. Such cases exist, a combination of IL and transthyretin amyloidosis. My question to you, yes, it's all very clear that chemotherapy in AL amyloidosis and the prognosis is much worse versus transthyretin cardiomyopathy. So we have to deal very fast with this problem, with this pathology. But in this situation, do you prescribe tafamidis or not in case of AL and ATTR? Well, you are right. If the patient has combination of IL and ATTR amyloidosis, well, mainly more urgent is hematology part of this disease. But if this is sustainable hematological remission with high-dose polychemotherapy, then such patient could get Consilium, and we had such cases, and then we recommended to prescribe targeted treatment for transthyretin amyloidosis. But primary and the most important for us is the, let's say, hematological response for chemotherapy. Thank you very much, Igor. Thank you very much. Please, let's check chat. Yes, we have one question, but I think this question is to you, Sergey. Please advise, what do you think? What should we be guided by for the primary screening of amyloidosis? Is it cardiac MRI or maybe echocardiography? Well, the simplest here, the simplest way is to be guided by ultrasound, cardiac ultrasound, because MRI by now is not the main method of examination. We consider it is an extra method. And again, coming back to the data of dear Fernando, he showed us that it is ultrasound which mainly allows us to suspect amyloidosis in our patients. And this is the thickening and other features. So please appreciate me and Igor, we never speak about hypertrophy. In amyloidosis, there is no hypertrophy. This is a thickening of the walls due to amyloid depots. That's first. And then cherry on top, Yes, this is also one of the main methods which allows suspect amyloid cardiomyopathy. I'm not speaking about transthyretin because we see, unfortunately, in case of AL amyloidosis, by the way, in case of AL amyloidosis, scintigraphy is also very useful, and it gives us sometimes accumulation of radiopharmaceutical. Yes, if the process is really advanced and in the protein accumulation zone, there is necrosis zone, and then as a result, scintigraphy could show us grade 2, grade 3 by pyrogeny as well in case of AL. So let me add on one comment to what Sergey said before, and also the experience of our Spanish colleagues. So they look at echocardiography and cardiac MRI. Well, it is reserved for diagnostically unclear cases or maybe for the resolution of other issues. Yes, comprehensive examination, that's the most important, what we have to offer our patients today, but also the doctor who is treating the patients or diagnosis the patients should suspect amyloid cardiomyopathy. So the most important is to suspect. So this knowledge of red flags is very important. And we have to try to understand that amyloidosis now is not such a rare disease, not rare anymore. We have to understand that amyloidosis, in fact, is very severe disease with a very poor prognosis, and we have to talk about it. So, wrapping up our discussion, I would like to say that we have experience of heart transplantation in amyloid cardiomyopathy, in transthyretin cardiomyopathy. We have this experience, and today in the publications, in the works, international works, it has been shown that yes, it is cardiac transplantation to these patients that may prolong life, not may prolong, but prolongs the life. So, dear colleagues, it looks like the time of our webinar, international webinar, is over. We are extremely happy that we had these 90 minutes. It was really a pleasure. We should understand that this disease is actually capital punishment for the patients if we don't diagnose timely, if we don't treat them timely. This is capital punishment. So, all our efforts should be mainly focused on early diagnosis. Well, our country is very big, starting from Kaliningrad in the west up to Kurilsky Islands in the east. We should establish many excellence centers. It should not be just Moscow site that accept patients from Vladivostok, because it's 9,000 kilometers, from Kaliningrad, 3,000 kilometers. Yes, we need to establish regional centers, regional excellence centers for the diagnosis and treatment of patients with amyloidosis, regional centers. So it would be ideal to establish such a network of centers like in Spain, and then simultaneously you can examine patients completely and then treat them immediately with AL amyloidosis, with ATTR amyloidosis. So they have both teams, and this is our dream, to have both teams under one roof. So once again, dear Fernando, thank you very much for your connection, for participation, for sharing your experience. As you see, we're also happy to speak up about our patients that we follow. And I want to confirm that we saw such unique patients, combinations of AL and ATTR. We also had the patients with heart transplantation with ATTR, and actually we took biopsies and biopsies of transplants was done, biopsy of graft was done later on, yet no deposits, by the way. And recently we see more and more interesting publications about the opportunities of transplantation to such patients. So, dear colleagues, dear audience, thank you very much for connecting today. And let me make an announcement that on September 9, we will have another international webinar, Revolution in the Diagnosis of Transthyretin Cardiomyopathy. That would be clinical experience sharing with Professor, specialist of nuclear medicine, Professor Jorge Carlona Arbonas. So please welcome the same place, the same time, September 9, 6 p.m. So once again, dear colleagues, thank you very much. Well, hopefully these 90 minutes were very exciting and you found something new for yourself, or maybe you repeated what you already knew before. And hopefully our webinar will help you to diagnose timely and properly cardiac involvement in transthyretin amyloid. Thank you very much. Have a good evening and goodbye.
Very much.
So we are off the air. We are off the air. So, dear Fernanda, thank you very much. It was really a pleasure.
Yeah,
Thank you for the
too.
connection and for Q&A and for everything. Thank you. It was